I'd like to thank Alan for giving me some homework to do over the Christmas holidays. But it's a very interesting book. It's a very heavy book in some chapters. There are some eyes glazing over portions to it. But I'll try and get to the basic messages that the book has, which may not ultimately be a surprise to you. So I guess a little bit about myself. I'm a family physician. I see a lot of people over the age of 65. That's the bulk of my practice. You kind of grow into these things after 40-some years in doing the thing. The first 16 years of my practice was primarily in rural communities in Canada, where I did family medicine and anesthesia and obstetrics. And so some days I'd be giving an epidural to a lady, and rather than deliver it myself, it was a difficult delivery, I'll let the GYN do it. But after 16 years, life became simpler when we moved down here. But it's interesting to see the two different systems. I could spend 4 hours talking about that, but we'll avoid that for the moment. So basically we're talking about the book Super Agers by Eric Topol. And Eric Topol, for those of you who don't know, is the Executive Vice President and a Professor of Molecular Medicine at Scripps Research, San Diego, the largest nonprofit biomedical institute in the United States. He's also a founder and director of the Scripps Research Translational Institute and a practicing cardiologist. He's one of the top 10 most cited researchers in medicine, known for his groundbreaking studies in AI in medicine, genomics, and digitized clinical trials. And he's on Substack, he has podcasts, and he does all sorts of interesting things. So basically this book is, I guess, elucidates a thorny problem. How do I get to age 122? Do I want to go there? And when you deal with difficult and thorny problems, the first thing is to be a religious fundamentalist in the good sense. In other words, you go back to the fundamentals and you try to adhere to them religiously. And so he starts off very appropriately with the fundamentals, which are basically lifestyle plus. And the absolute bedrock fundamental in lifestyle plus is diet. There have been various diets touted to you over the years, the ketogenic diet, the DASH diet, and the Mediterranean diet. So the consensus right now in this book is that the Mediterranean diet is the best diet to follow. And we'll go into that, but basically processed foods is the worst diet to follow. So anything that has more than 3 ingredients, anything in a bag or a box, anything that has a whole long list of ingredients, you should try to avoid in any significant sense. The more you eat out, probably the more you're eating processed foods. You should endeavor to cook for yourself as much as you can, or find someone who knows how to do that. Fortunately, I have this wonderful resource called a wife, and I've benefited from her cuisine for many years. And I suppose the way I look depends mainly on her. So the totality of the data support the lack of hazard for coffee and caffeine. It can sharpen your brain up a little bit. Some people, it makes them sleepless and irritable, but in general, it's not going to kill you, and it may even benefit you somewhat. So if you like coffee, go for it. The question is, we're not talking about a frappuccino, right? We're not talking about a lot of dairy products and sugar going into this. We're talking about, so I'm a black coffee drinker. I've grown up over the years. Alcohol, less is more. I would not recommend any more than 1 drink per day. And I've been drinking less and less over the years. I see people who drink 2 glasses of wine in the evening, and I look at their blood, and one thing that shows up is their blood cells, the red blood cells tend to enlarge if they do that. And I'm saying, okay, there's something going on the body doesn't like about alcohol. So you want to limit that to about 1 drink per day or less. Fish is good. The fats and the oils in fish are good, particularly salmon, herring, the oily fish. The smaller fish are good, obviously, because they haven't been eating other fish which contain mercury, and so they haven't concentrated a lot of mercury in their little bodies. So, but salmon, I eat that regularly. Red meat is bad just because of a lot of antibiotics and other drugs go into it and the processing of it, and because of the saturated fat. And so probably there's a carcinogenic aspect to it. It's not that I don't eat red meat, but I eat it less than once a week. Poultry, 2 or more servings may increase cardiovascular risk, he says. So what about the Mediterranean diet characteristics? A lot of olive oil if you're cooking with oil, so you can cook with olive oil to the extent possible. Tree nuts and peanuts. So you may make sure you have a lot of nuts in your diet. They're very good. Number one, they have magnesium, but they have a lot of other nutrients. And seeds as well, chia seeds, that sort of thing. Fresh fruits, obviously, vegetables. Different color vegetables do have significance in terms of the micronutrients within them. And so you don't want a brown and beige plate. Okay, you want multicolored plate, and you're only going to do that with vegetables and fruits. And particularly, berries, particularly you want low glycemic fruit, which is more what you get in Oregon as opposed to the South, okay? So you think about fruit, think more Oregon, Washington. So what are you going to get there? You're going to get berries, you're going to get pears, you're going to get apples. You're not going to get citrus. You're not going to get pineapple, which is one of the highest glycemic fruits. So you tend to go more north with your fruits. But any fruit is probably better than hard candy or chocolate. Well, he didn't mention chocolate too much, but anyway, not that I don't eat it. Fish, legumes, basically vegetable. And sofrito, I hadn't heard of the word sofrito before. I looked it up. It's kind of like anyone know what sofrito is? No. It's kind of a salsa type of thing. It's just a lot of tomatoes, onions, and herbs all kind of chopped up. And apparently you use it as a starter for some recipes and so forth. So everybody go home and look up sofrito and eat more of it, I guess. White meat instead of red meat. Wine with meals, again, it's part of the Mediterranean diet. Not sure how beneficial it is, but you want to limit yourself to a glass per day. And obviously you're discouraging soda, commercial bakery goods, sweets and pastries, spread fats, red and processed meats. So there's something, a lot of people are trying intermittent fasting, and he couldn't find a lot of solid data for intermittent fasting. There is some benefit to a long period of time between when you last eat and when you first eat in the morning. So I think your intermittent fasting could be confined to 12 hours between 7 p.m. and 7 a.m. And that can have a lot of benefit in terms of your metabolism. So you don't have to starve for a full day. He said there's probably just as much benefit in making sure you don't munch all into the evening and go to bed full. You should probably go to bed with an empty stomach, and 12 hours I think is reasonable. But the more long periods you can put in your week without eating, probably the better for your health, long-ish periods. No clear role for vitamin supplements like Prevagen and that sort of thing. They don't really have good science behind them. I don't think they're harmful, but we don't know what else is in that little tablet. And lifestyle, again, do this. Get together with your friends, socialize, don't be isolated. The more isolated you are, the more stimulation deprived you are, the more lonely you are, and that's not good for your overall health. Exercise, of course. You want to get outside to do a lot of your exercise. I would do as little as possible inside unless you're just not able to get out there. At a minimum, if you're just walking, 1 hour per day of walking is recommended. If you're going to do more vigorous exercise, like aerobic exercise, you can do 20 minutes a day, something like that, 20 to 30 minutes a day, so 3.5 hours, whatever that works out to, 5 to 7, 3.5 hours, something like that per week of moderately vigorous exercise. There's no benefit really of doing decathlons or extreme exercise. That may be more harmful. So I know a lot of you are wanting to do that, but I'm going to be discouraging. We'll go into that a bit. There's something else about that later on. Include resistance training in your weekly routine. You should be lifting weights, not big ones. Don't strain yourself, but start out with the small ones and do resistance training as part of the weekly routine. Topol said that he is a cardiologist, and he never really recommended resistance training until recently, when the research seems to go in that direction, saying you do need to build up your muscles as well. Balance training is important as you age. You want to be able to, if you tip, you want to be able to catch yourself and not fall. And do not sit for long periods. Well, I'll try to not keep you too long, but basically sitting, the body was not designed to sit. Sitting was invented, the chair was invented, it's a medieval Europe construction. People in Iran and Japan, at least until recently, would eat on the floor on very low tables. They would sit cross-legged on the floor and eat, and you can still see people going into a room with a carpet. India, same thing. They're eating on the floor. And I couldn't possibly do that now because my joints are I'm so used to chairs. But sitting is not healthy for the body for long periods. It kind of deteriorates your back and that sort of thing. It's not just good for your metabolism. Sleep, 7 hours. 7 hours of sleep. I don't know how to duplicate that for you if you cannot sleep unless you retrain yourself to sleep. I don't think, I do prescribe sedatives for people who really want them. And I say, basically, I'm prescribing the sedative for your comfort, not necessarily for your health. And I may be prescribing a hip fracture for you. Because if you get up in the middle of the night under the influence of a sedative, you may trip, fall, particularly in the bathroom, and break something, and that could be a very, very major life changer for you. So I don't recommend sedatives. So there are, I haven't put this on here, but there are a couple of good, what we call cognitive behavioral therapy. You used to be able to go to a cognitive behavioral therapist to do that, but it'll take you 2 years to get an appointment. There are self-help cognitive behavioral therapy phone apps now, like CBT-I, that's CBT-I, and also Insomnia Coach app, Insomnia Coach from the VA. Apparently it's free from the VA. And you can look into those apps and try to retrain yourself to sleep properly. But natural sleep will tend to cleanse the brain of a lot of waste products that if you don't get good sleep, those waste products are going to stay there and perhaps will accelerate the development of dementia. So you want to be able to sleep naturally, and you ought to be able to want to be able to try to retrain yourself to do it. But 7 hours is about the right amount for most people. Excessive than that may be more harmful than good, because then your muscles are going to start to waste and all sort of thing. Sleep apnea, you all know what that is. You lie down at night, your tongue drops back into your throat, and you start, and then you're going, and you're waking yourself up, and you're rocking rather than breathing, and that's very, very hard on the cardiopulmonary unit and can lead to atrial fibrillation and a few other things. So if you've got sleep apnea, you ought to address it and get it treated. There's all sorts of tubes and things, but there are other measures to do. Sleep on your side, I guess that is the first thing you want to do. Then he goes into chronic killers, obesity, diabetes, cardiovascular disease, cancer, and neurodegeneration. Well, with respect to obesity and diabetes, GLP-1s, you've all heard of those now, like Ozempic, Wegovy, Zepbound, Mounjaro, particularly. Those are the leaders. And they mimic hormones from the gut cell lining that make you feel satisfied. When you take this, and they're weekly injections, they're coming up with oral pills now. They slow the stomach emptying down so you feel fuller for longer and you're satisfied with less. They do get rid of hunger. A lot of people say that they're not really thinking about food nearly as much as they used to. They seem to go to the hypothalamus as well and influence cravings. And people who have other addictions and dependencies find that they tend to be less of a problem as well. So it's being looked at in terms of drug addiction treatment and so forth. And they really have been revolutionary. I do prescribe a lot of them. They have long-term benefits in terms of heart, stroke, kidney, and they started off as diabetes drugs, but the kidney specialists love it and the heart specialists love it as well. Anyway, so that basically, that's the newest thing in terms of obesity. The metabolic syndrome, they treat the metabolic syndrome. So the metabolic syndrome involves 3 of the following: abdominal obesity, more than 40 inches around in men or 35 in women, or a BMI of over 30. BMI of over 40 is a morbid obesity. That's a real bad thing. High blood pressure, high triglycerides and low good cholesterol, low HDL cholesterol, high fasting glucose. So if you have 3 of those, you can be considered to have the metabolic syndrome. The importance of the metabolic syndrome, it is that it is an inflammatory condition. And the role of inflammation runs right through this book. It's one of the big fundamentals, big theme throughout the book. Back to GLP-1, so they reduce inflammation. Basically, you can mimic GLP-1 simply by losing weight. The trouble is, losing weight is not that simple. And our bodies seem to have a set point where we want to stay at 172 pounds, and we can't seem to get below that. But the question really is for GLP-1s and GIPs, whether this is going to be a lifelong commitment for you if you do this. And in diabetes, it probably is. But if you just have obesity, what happens when you stop? In most cases, you're going to regain the weight if you stop within a year. They haven't been out for that long, so we don't have any data on people who've taken it for 10 years yet and then tried to go off it, so we don't know what's going to happen. So these are short and medium term propositions right now. They haven't been around long enough to define the long term. But they have positive effects on heart disease, kidney disease, fatty liver disease. You've heard of fatty liver, and fatty liver can lead to liver tumors and cirrhosis. Dementia and Parkinson's disease. There's some, I think any way you can lose weight is going to help with dementia, because dementia is partly due to inflammation in the brain, and you're reducing inflammation. They are indicated, and they have an FDA indication in treating sleep apnea now. So it's one of the ways, if you want to treat sleep apnea, lose weight, and your sleep apnea goes away. Also, your heartburn goes away. Polycystic ovary syndrome is a particular type of problem where you're infertile. You have kind of an apple rather than a pear shape as a woman. And it's been treated with metformin for many years, but now the GLP-1s seem to also be very effective. Side effects of GLPs and GIP-1s include bloating. You can think if your stomach is not going to empty soon, if you overdo it in terms of the dose, you may get bloating, nausea, vomiting, abdominal pain. That may simply be rectifiable by going down to a smaller dose. And it comes in dosing ranges from 0.5 up to 10. You kind of gradually go up over month by month to find the least dose that will give you a comfortable weight loss. I wouldn't use them if you've had a bad history of pancreatitis. It causes fat loss, but it also causes muscle loss. It causes loss of mass. And so you can militate against that by doing the resistance exercises that I discussed before. So if you're using it, you must exercise. Apparently there's some increased heart rate. I haven't noticed that much, but maybe so. Optic neuropathy, I haven't seen that, but probably I haven't been long enough with the medication to see that. But there's some suspicion it may cause neuropathic problems with the optic nerve. So more on diabetes. It used to be the bedrock drug was metformin. You always started with metformin. And metformin is mentioned along the book as possibly a good lifelong investment for other reasons. So I wouldn't give up on metformin entirely. It's really cheap. It makes you more insulin sensitive, but its effect on weight loss is pretty minimal. So the two drugs that we're going to that really make a difference not only in your numbers but in your risk of complications are the GLP and the SGLT2 drugs. The SGLT, sodium glucose transporter drugs, are things like Jardiance and Farxiga. And what they do, you take a pill a day and it makes you pee out glucose. You're peeing out calories. But the cardiologists and the nephrologists are really keen about these drugs too. They do help people in heart failure. They do help people with chronic kidney disease. And they do lower the risk of diabetic complications and other outcomes for non-diabetics. So they are rather powerful drugs in terms of long-term outcomes. So he discusses statins, of course. We're using statins for cholesterol. You've all heard about statins. Anyone hasn't heard about statins? So there's a lot of, they've been in the drinking water, not quite, but they've been prescribed now for many years, for decades, and there hasn't been a massive outbreak of anything adverse. There are side effects of these things, but in general, they've stood the test of time for people who can tolerate them, and there are people who cannot tolerate them, mostly because of lack of muscle aching. And so there are choices beyond that, but these are the bedrocks for if you want to reduce your risk of heart attack and stroke and lower your cholesterol, you use statins. Rosuvastatin is my favorite, but it also has a reputation for causing diabetes, maybe 1 in 167 people. So you have to keep an eye out for that. But people who have diabetes are advised to take statins. So there's a little bit of a discordance there. But they are important in terms of if you have diabetes or if you have vascular disease of any type. And if you have some types of kidney disease as well, whether your cholesterol is high or not, statins are often recommended because they do reduce the risk of certain adverse outcomes. So what about heart disease? For all we can talk about cancer and everything else, heart disease still is the leading cause of adult mortality. It started going down, heart disease started going down in terms of incidence until about 2010, and now it's going up again. Why is it going up again? Mortality is going down because of the drugs, but the incidence is going up. And I'm suspicious it's because of our diet culture in North America. And we're just getting too much of, basically too many high refined carbs and saturated fats. So this is basically what your arteries look like when you're born. They're nice and smooth. And then we consume the North American diet over many years. And when you're 20 or 30, you start roughening the lining of your arteries. And so that roughening of lining, there's a healing response that happens, which is called a plaque. The trouble is the top of the plaque is kind of rough as well. And so there's plaque upon plaque upon plaque. And so the importance here is there's inflammation going on. There's inflammation going on because of the type of diet we've been exposed to. And it gets more and more and more. And what the final event is a piece of clot adheres to that rough lining and blocks the artery off completely and suddenly. And so you have a sudden event like a heart attack or a stroke. So you start with plaque. Plaque is rough. It attracts platelets. Platelets attract more platelets, and the clotting cascade happens, and you have a sudden event. But the one fallacy here is that you don't have to wait for this degree. Is that showing up? Okay. You don't have to wait until that bottom artery to have the event. You could have a sudden event on the second artery there in the back. It depends on how much inflammation is in your body. So an inflammatory, if there's enough inflammation in your body, and the source of that being the metabolic syndrome, everything we've talked about, then you could have a big clot in a big artery, like a coronary artery, with relatively little plaque, just because of the level of inflammation. Statins are anti-inflammatory as well as lowering your cholesterol. They work by two mechanisms. They lower inflammation, but they also gradually stabilize and shrink the plaque. And he talks about the things we can do to detect cardiovascular disease early, and there's a lot of stuff that goes into that. And basically, right now, would you do all that stuff if you felt well? There's some on that list that you might consider doing, like checking your HSCRP, a high sensitivity CRP. That determines to some extent the level of inflammation in your body. Obviously, you'd check your cholesterol. You'd consider a coronary CT scan, but the coronary CT scan will just determine how much old plaque you have. It won't really tell you what new soft plaque is on top of that. And it won't tell you when you're going to have your next heart attack because, as I said before, you could have a small amount of plaque, a lot of inflammation, and still have a heart attack. So you're still back to addressing the fundamentals in terms of what do I do to de-inflame myself. And coronary CT, that's the upper right-hand corner. That's a nice way of having a cardiac catheterization without having a cardiac catheterization. They put dye in your arteries. They put dye in your veins that goes to your arteries, and it can be outlined by CT scan, and they can get better and better pictures now of your coronary arteries without having to do a cardiac cath. But that's somewhat extreme. It's a lot of x-rays. Basically, a coronary CT, which costs about $250 to $300, is probably the equivalent of somewhere between 150 to 400 chest x-rays in terms of radiation exposure. Any CT scan is going to be like that. So you have to factor in that. You can, we all may have had a few over the years, that's fine, but you don't want to make a regular thing of it. Biomarkers, so in addition to lipid panel, the standard lipid panel, they're now recommending, the cardiologists are, that we get something called the lipoprotein A, which is a genetically determined level of a certain type of cholesterol, and we haven't figured out how to change that genetic level. So if you've got a high lipoprotein A, you're always going to have it. But that simply, if you have a high, it means we have to be more aggressive in lowering your cholesterol with higher doses of statins to get your LDL not only below 100, but below 50 or below 45, below 55. So it's something that's considered that everyone should have done once in their life, which is a simple blood test, a lipoprotein A. There are other more sophisticated or more complex, I would say, NMR lipoprofiles, but They were just always confusing to me. This seemed to be a relatively simple way to get to where you wanted to get to. But basically, if you want to prevent all this, we're back to diet. We're back to statins. And we may be back to GLP-1s and SGLT2 inhibitors. And we can talk more about that later if you have questions. Prevention, yeah, so we talked about ApoB is another type of cholesterol that can be done. CT calcium score. We talked about statins. So what if statins aren't quite enough? There's another small pill you can add on to a statin called Zetia. Ezetimibe is the fancy name, it's Zetia. Nexletol is something you can add on. So you can take all three of those if you needed to get your cholesterol down far enough. If you cannot tolerate these drugs or you want to be aggressive in another way, you can use injectables, which are once every couple of weeks or once every 6 months. Repatha, I think, is every couple of weeks. Inclisiran or Leqvio is like every 6 months. You really have to see a cardiologist about the inclisiran. But Repatha comes in injectables just like Ozempic does. You just go bang on your abdominal wall every 2 weeks. And these have been very helpful for people who can't take statins. And even for people who want or have a high risk, you can take both statins and these medications. Atrial fibrillation is something you want to avoid. If you have an irregular pulse, in other words, it's not boom, 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 it's boom, 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 boom. So it's irregular. The chances are you could have atrial fibrillation. Your smartwatch, if you have one, will give you a hint that you may have this, and you should see your family doctor or your cardiologist about it, because it increases your risk for stroke about 5 times normal. Now, the reason is because the atrial chambers at the top of the heart are fibrillating. They tend to not push things out. They tend to get sludging and clots develop in the left atrium. If those clots get into the left ventricle and get thrown up into the brain, that's not a good thing. You have an embolic stroke. And so people who have atrial fibrillation of a significant amount are advised to be on lifelong anticoagulation, or they can have a Watchman device put into the left atrium. So all they have to do then is take aspirin. And there's a 25% risk after age 45. Now, I've been at this for 40 years. Every year there's more and more of it. Probably part of that is just because my clients are aging, and the whole population has been aging. But there's a lot more of it than there used to be. So what are the risk factors? Obesity, sleep apnea, hypertension, diabetes, smoking, lack of exercise, COPD. What do you expect? Thyroid or kidney disease, mental health disorders, extreme endurance exercise. So that's where the decathlons come in. It's not, you don't have to do a decathlon. It may actually increase your cardiac risk, particularly of atrial fibrillation. And gum disease. So think about your oral health. This is a potential source of inflammation right here. And you've got to make sure your gums and teeth are in as good shape as possible. If you have a chronic source of infection anywhere in your body, and your mouth is one of the most common areas, you're going to have high levels of inflammation that could be toxic to your heart and could roughen the inside of all your blood vessels. Cancer. What you got to realize about cancer is probably it's detectable, it's been there for 10 years already. It obviously starts as a single cell that never gets recognized by your immune system and continues to, and it has its own immune checkpoints where it can fend off, somehow it's figured out how to fend off your immune system. Normally you're developing cancer cells all the time and your immune system is detecting them and killing them, but for some reason the immune system is not detecting some cells and they grow and they cause cancer and then they spread. Obviously there are genetic, environmental, and inflammatory, and a good instance of inflammatory cancer would be gastroesophageal reflux disease. You can get esophageal cancer from very severe gastroesophageal reflux disease because of the acid inflammation of the lining of the stomach. Obviously, there are lots of pollution-related cancers from carcinogens in the atmosphere, pesticides, that sort of thing. Overuse of antibiotics is a suspect influence, and Lord knows we've had a lot of antibiotics put into our bodies over the years. So your microbiome is, again, another thing that runs through this book in terms of the importance of maintaining a healthy microbiome. And the best way to do that is to eat healthy, eat the Mediterranean diet. But these days, in terms of the cancers, In the old days, we used to say a cancer in the lung is different from the cancer in the bowel, is different from cancer of the pancreas. Now we say we've got to look at that cancer on the DNA level. Look at its DNA, look at the genetic characteristics of the molecule. And so they're better defined now by their genetic characteristics and their molecular characteristics than by the organs that they're in. And treatments are targeted in that way more and more now. Present screening capability is inadequate. We can screen you for colon cancer quite effectively, prostate cancer quite effectively, breast cancer is pretty effective. Pancreatic cancer is a lost leader. It's really, by the time you have symptoms of pancreas cancer, it's too late. We haven't found a good overall public screen for pancreas cancer. And so what about genetic screens? These genetic screens are developed, there's something called Galleri, Galleri, where you can get a whole genetic profile done. And it may say, okay, you're at risk for developing pancreatic cancer. Okay, what do I do about that? Do I get a CT scan once a year? Well, pancreas cancer within a year can be not visible and visible. It's pretty fast once it gets going. There's a certain exponential point. Secondly, CT scans are a heavy dose of radiation. What about an MRI? Well, we want to detect it early. You want to get an MRI every year. There's no insurance right now that's going to pay for that because it's not in the guidelines. It might make sense for some people who have lots of money. So basically his point there was that the tests like this are for the curious affluent. We haven't got to a point where there is a public standard for surveillance of someone who is at risk genetically for these pancreatic or lung cancer. For lung cancers, there is a screening program for people who have not quit smoking within the past 15 years and who have had a more than 20-year smoking habit, or 20 pack years, which could be 2 packs a day for 10 years. That's 20 pack years. So if you smoke like that, there is a CT scan that we can get for you that would be covered by insurance. But in general, guidelines are we don't really have good screens beyond those screens I discussed. There is some value developing in terms of AI interpretation of imaging, like breast, like CT abdomen. Maybe they can see that tumor a little bit better than the radiologist could. And so that's kind of in development. I'm not sure how much John Muir is doing of that yet, but I think the value is being recognized and it's becoming more and more, it's becoming closer to a standard. And genetic profiling of diagnosed cancers definitely improve treatment outcomes. So they are looking at the genetic characteristics of all those cancers. In general, that was a very complex and detailed and difficult chapter to get through. There's loads of research cited in that, and at a certain point your eyes start to cross, but it's all in there, put it that way. Cancer treatments, we're now getting into immunotherapy, monoclonal antibodies, and they are immune checkpoint inhibitors. As I said, the cancer cell has developed a checkpoint where it can check the immune cell from affecting it. And so if you get in there with a certain type of little antibody that's manufactured, you can shut down that checkpoint inhibitor and the immune system will now recognize that cancer cell and kill it. But there's always a chance of some side effects where the antibody starts recognizing other tissues and starts affecting those too. So there are immune side effects such as colitis and a few other side effects you can get sometimes from these inhibitors, but they do represent a major advance. I've had people I have one patient who has had malignant melanoma, metastasized to his hip, metastasized to his brain. They treated him with immune checkpoint inhibitors. It's been 10 years now. He's still out there doing his thing. And metastatic melanoma used to be a death sentence. So they are a definite advance, and they're worth the trouble that they may sometimes cause. It's worth trying them. Bites I don't know much about, but they're for liquid cancers, in other words, the leukemias and that sort of thing. They're bispecific T-cell engagers. They're working on viruses that can infect the tumor cell and inject stuff into it. Success so far is largely short-term, he says, but I don't know, that guy was 10 years is pretty long-term. Anyway, it was a long, complex, and confusing chapter, and you can enjoy it at your leisure. Neurodegeneration. Okay, we're talking about dementia, Alzheimer's, and the various other types of dementia, Parkinson's disease, and it's felt to be due to, Alzheimer's particularly, is felt to be due to the waste proteins that accumulate. So the amyloid accumulates between neurons, and the tau protein accumulates inside the neuron, and together they cause degeneration of the neuron and make you demented. It does appear that that's one of the functions of sleep, as I mentioned, to help clear the brain of these accumulated waste products. So you got to sleep naturally. The screening for this, there is some value to the p-tau 217. If you are very early in the course of what you suspect is dementia, and you have a positive p-tau 217, it's something worth perhaps talking to a neurologist about. There are monoclonal antibodies for that, and they are FDA approved, but there's high risk for limited benefit. In terms of limited benefit, they were offering, we have medications now like Aricept that will slow down the rate of decline. And so the people who get these new drugs, basically they have to have blood tests and MRIs every 3 months. They have an infusion every month or every 2 to 4 weeks. And they go back, have an MRI, make sure there's no bleeding or swelling of the brain. And so one of the side effects is brain swelling or brain bleeding. But the people who survive all that, they've now documented 4 years out, and perhaps there's been about an 8-year postponement of progress from mild Alzheimer's to moderate Alzheimer's. So there may be some value there, but it's a whole process. A very difficult long-term, well, I don't know how difficult it is, but it's certainly involving, and it's involving you go to the doctor regularly and having regular infusions and regular MRI scans to make sure the infusions aren't damaging you. But those are another form of monoclonal antibody. Natural risk, the more walking you do, you reduce your risk. Mediterranean diet reduces your risk. Maintaining normal weight reduces your risk. Sleeping 7 hours. Again, we're back to the religious fundamentalism again we talked about earlier. Maybe get the shingles vaccine. What's that all about? So there is a new article in the past week in the New York Times that talked about vaccines are helping older people more than we knew. There was a study done in Wales where the public health system said, if you have not turned 80 yet, you can get the shingles vaccine. And so that happened, and about 50% of the people who hadn't turned 80 yet and were say over to 65 got the vaccine, and the others were kind of out of luck because it's a pretty expensive vaccine. And the researchers said, we have an ideal population here. We've got people that are 79 and a half, and the people are 80 and a half. We can compare those two populations, and they compared them, I guess, for various things. They found out that there was a very significant reduction in Alzheimer's disease in the vaccinated population compared to the unvaccinated population. The only real difference between those two populations was like 6 months of age, all right? And and they're seeing other benefits in terms of reduced risk of heart failure, stroke, that sort of thing, in people who have had a number of different vaccinations. It's a very interesting article to read if you get the New York Times. Vaccines are helping older people than we do. So the theory is that you get real bad COVID, for instance, if you get a real bad infection, you're in hospital, you get long COVID, there's a lot of inflammation going on over a long period of time. If you are vaccinated, you have a brief period of inflammation, and then when you get COVID, you have another brief period of inflammation, and that's it. You don't have chronic inflammation from very bad encounter with a virus. And so it basically is suspected that it prevents more disease than you think, put it that way. So preventions of Alzheimer's disease, what do we do to look for clinical factors? It's a rather complex slide. I can't even read it here. Polygenic risk scores. Yeah, okay. The retina is the only, in the upper right-hand corner, is the only place in the body where you can see bare blood vessels. And so if there's an extensive blood vessel process going on, that might be one place you can see it. So those retinal photographs you get at your ophthalmologist may be of value in terms of finding things for various reasons. Brain MRI doesn't show much in Alzheimer's disease, although the PET scans, there are metabolic MRIs that will show it. That's true. brain organ clock. I forgot what that was all about. But you should maintain good vision and hearing, because if you have poor vision and poor hearing, that represents a lack of relative sensory deprivation, and that can accelerate the development of dementia. So you want to wear your hearing aids and wear your glasses and keep in touch with the rest of the society. Preventive strategies are aggressive lifestyle modification, immune inflammation, anti-amyloid agents. We talked about those are the MABs, the monoclonal antibodies. Gut microbiome modulation. How do you modulate your gut microbiome? I think what they did was they transplanted the fecal material from demented rats into non-demented rats, and the non-demented rats became demented. They did the reverse, and the demented rats got better. So maybe if you would like to ingest the feces of someone else who's healthier than you are, there may be something to that, honestly. And there are fecal transplants that are done now for people who have Clostridium difficile colitis, which is very difficult to treat. And so they treat you by putting an NG tube down and putting some fecal material from a healthy person. And that, if you've had multiple courses of antibiotics and it hasn't helped, this may help. So it works in that sense. But there's a lot. He talks about the microbiome, and what we're talking about is the bacterial balance in your gut. And he talks about the microbiome in multiple chapters, saying it's a good thing to, well, I'm not sure how you exactly modulate your microbiome except by eating healthy and eating a lot of yogurt or taking probiotics. Probiotics are harmless and potentially beneficial. Parkinson's disease, reduced risk with exercise, caffeine, and smoking. So he's not recommending smoking, but if you're a smoker, you're less likely to develop Parkinson's disease and you'll get everything else instead. But there you go. Statistics are statistics. Early detection with retinal imaging, I guess that's where it comes in. I hadn't known that, but there you go. All the treatments we have in Parkinson's do not necessarily slow down the rate of decline, but they do help with the symptoms. They help you move better and so forth. But eventually it's going to catch up with you, and there's a dementia process at the end of it. Late in the process with Parkinson's, you will get a dementia, you may get hallucinations and that sort of thing. So again, MAB therapy, which is monoclonal antibody therapy, is on the horizon, and there may be a role for the gut microbiome and fecal transplant. Line up for that. And perhaps GLP drugs we talked about it has positive effects on many outcomes, and they're talking about maybe it helps with Alzheimer's and Parkinson's. But the GLP drugs to a certain extent are just forcing you to eat less, which is probably a good idea. If you ate less in the first place, maybe you'd be just at less risk. But there may be more to GLPs even than that. We don't know yet. Stay tuned. Then there's the chapter on curing rare diseases and gene therapy and gene editing with CRISPR. And that was quite a slog. And just to say that it's out there, but they're doing the rare diseases first, because the consequence of messing with your genome could be very serious. And so you want to have a very serious incurable situation before you embark on this. There are other gene therapies for other things, but it's not the first thing you'd want to try for diabetes or something like that. There's other things you can do. Rare diseases first. This was just an interesting nanoparticle. These are, I believe, in your COVID vaccine, the mRNA vaccines. So basically they're particles covered with a fat membrane that have to get somewhere. And described it here on page 200. I remember that. So to get where the nanoparticle needs to go, the CRISPR-encoded mRNA, which is in the center of that, in that square there, would have to withstand being buffered about in the bloodstream where the immune cells are roving, and then fan out into the forking of network of vessels winding through the liver, slip through a pore in one of these vessels' walls, fuse with the surface of a liver cell, get sucked across its protective membrane into an endosome, and somehow escape before the endosome became mRNA meltingly acidic. Only then could the CRISPR even have a chance to do its job. So I don't know how they did this, but there are nanoparticles that they've invented that can go to a target cell and modify it so that it will create the right antibodies that you want. And they're used both for this and for I'm not sure if they're using the specific cancer therapy, but they're a fascinating thing. Controlling our immune system, so basically that's our next step. Basically we're talking about autoimmune diseases like rheumatoid arthritis, lupus, multiple sclerosis, type 1 diabetes is an autoimmune disease, the kids disease, thyroid disease. A lot of people have Hashimoto's thyroiditis or other viral thyroiditis. It's an autoimmune disease why do people become hypothyroid? Probably because of autoimmunity. Obesity is a risk factor. The gut microbiome is different in autoimmune sufferers. How do we work on that? Caloric restriction will cause T cells to reprogram to be anti-inflammatory. So again, you're probably affecting your gut by doing that, and that has an anti-inflammatory effect on the T cells that are the culprits. They kind of reprogram the T cells. No true preventive strategies available yet. The first drug to delay the onset of autoimmune disease for type 1 diabetes has now been invented, called teplizumab, MAB, monoclonal antibody. So it's out there, but I'm not a pediatrician, so I don't get to use that drug. Only the endocrinologists do. What about antibiotics? What about vaccines, first of all? The vaccines of the past took decades or at least 8 years to develop. They thought it might take 8 years to develop COVID vaccine based on what we had available. Operation Warp Speed under the Trump administration. It took 10 months to develop this vaccine, 10 months instead of 8 years. The Trump never took credit for that, never emphasized it. It's probably one of the big things that happened during it, but never emphasized it. Similar rapid development after that for the RSV vaccine, respiratory syncytial virus. It's a viral pneumonia that can hospitalize people over 75. So people over 75 and small children, babies, are advised to have this vaccine. RSV causes bronchiolitis, which hospitalizes a lot of little ones, but also old ones as well. The flu shot. Again, I talked about other reasons you might want to get the flu shot now because I'm selling flu shots. But 20 to 50% effective in terms of preventing you getting sick, but it prevents you from getting hospital sick a lot more than that. It may reduce your hospitalization risk by about 75% if you're over 65. So it's still worth getting. You still may get sick, you may not get that sick. No vaccine yet for hepatitis C. We do recommend one-time screening for hepatitis C. Hepatitis A and B we have vaccines for. Hepatitis C you can have for years and not realize it. It does be asymptomatic for years, and then finally it's been eating away at your liver, and some of the people need a liver transplant or are very ill. So it's good to get screened for it, and you should check with your doctor whether you've been screened once in your life for it. And they are working for mRNA vaccines for all sorts of stuff, like malaria, TB, HIV. Again, the nanoparticles come into that. Inhaled vaccines for flu and so forth actually may be more effective than injectable vaccines, but they are more expensive, so they're not widely used. I'm not sure they're covered as well, but if you get the flu because of it's inhaled against your respiratory lining, your upper respiratory lining. That's where it happens, that's where it gets into the system. And so if you can protect there, rather than having to go all over your body to get there, it may be a more effective way to go. They use IgA lining antibodies rather than IgG humoral antibodies. But there are some nasal inhaled vaccines. They monitor for new epidemics now by monitoring the wastewater. So they can tell what's new from what you're all pooping out. And it's all down there just for them to go get it. And so they do the genetics down there and they find out what's going on. And there is a school of thought that says natural immunity is better than injectable vaccine immunity. That has been proven wrong in human papillomavirus, which is HPV, which causes cervix cancer. Vaccine is better. Natural immunity never cured cervix cancer, or never prevented cervix cancer. HPV has been very successful at doing that. So all your teenagers need to get vaccinated with that. HIV is another example. Shingles, we don't become immune to shingles. Shingles virus stays in our spinal column for years after we've had chickenpox, and every once in a while when our defenses are down, it grabs us and creates this painful rash somewhere. And the shingles vaccines we have will prevent that fairly effectively. And also, I guess, prevent dementia a little. Tetanus vaccine. We never got immune to tetanus, but we have a vaccine for that. So there are some examples that vaccine immunity is better than natural immunity in many, many cases, maybe more than we think. Epstein-Barr virus, mononucleosis, is associated with the developments of Burkitt's lymphoma and multiple sclerosis. No vaccine is available for that one. And obviously, natural immunity isn't preventing it. Well, probably your natural immunity may be preventing it in some cases, but not enough. No real new antibiotics since the 1980s. Can you imagine that? We really haven't had any major. I'm not sure what the outlook was on that from a financial point of view for the drug companies, but I think it has something to do with the antibiotic resistance, and this antibiotic's outdated before we can make money on it. But they're doing AI searches. They can go through millions of molecules, and they're looking for molecules that fit into receptor sites on a cell. And they're saying, okay, here's the E. coli, multiple drug-resistant E. coli. There's the receptor site that's going to kill it. We need to find a molecule that will glom onto that receptor site and affect the bacteria. And so they had to do it very laboriously, but now AI will speed that up. And hopefully, that's one way that AI helped. The other idea is sepsis. Sepsis is a quick way to die in a hospital from a very bad and overwhelming infection. And if you have sepsis, they're going to take a blood culture. And maybe we'll see something in the blood smear, maybe we won't. Maybe we can culture it. It takes 3 to 4 days. Meanwhile, we're guessing as to what antibiotic is used. Genetic sequencing now can take 6 hours. And you can identify a culprit bacteria by doing that. And so I know that's being done at UCI. There's some UCSF studies. So that's happening more and more. So if you can speed up the treatment, you're going to have less loss of life from sepsis, which can kill you. So timing is very important with sepsis. And our victory over infectious disease started maybe in the middle of the 20th century. In 1900, average life expectancy was 48 years. The main reason it grew to 79 in 2010 was infectious disease treatments. And now it's starting to go down again for a number of, I think, food cultural reasons, stress cultural reasons, that sort of thing. And also may go down further if science develops a further trust deficit with the public. So promoting mental health chapter, which is my favorite chapter, it seemed to be the most engaging chapter. And we often talk about, well, you should get more exercise, you should go outside, you'll feel better. There is actual solid scientific evidence for these specific non-drug recommendations for people. And they're important, at least adjuncts to any active treatment of severe mental health, but you need to do this. Increase your time outdoors. We don't spend nearly enough time outdoors. Getting outside away from the four walls that are echoing in your head, that makes a big difference to how you feel. Music therapy, and we have, particularly in dementia, people will be non-communicative. If you're asked their family what's their favorite music, you put their favorite music on headphones and they'll start singing and verbalizing like they've never verbalized before. So there's something about music, music therapy. Music in general helps with Parkinson's, heart, stroke, anxiety, stress, dementia. Sleep 7 hours. He mentioned the Oura ring. You may have seen that advertised. Apparently that'll tell you how much you're sleeping. It won't necessarily tell you what to do about it. But there are the digital apps where you can sleep better with. Digital CBT also for mood called the Wobot, W-O-E-B-O-T. Apparently you have conversations with these things and they actually help. Exercise is the same thing, exercise outdoors, but exercise makes a difference. And so there is solid scientific evidence for these recommendations rather than just off the cuff. Finding social connection and touch. Obviously that's why you're all here. Diet and the microbiome, we discussed it again. This theme runs through the entire book. The gut-brain axis, there's the vagus nerve connects the brain to the gut. And the various organ systems do communicate with each other much more than we thought. And apparently the microbiome can communicate with the brain via the vagus nerve. More on that in the future, I guess. GLP-1s may be helpful for anxiety and depression. I have had people come into the office Years ago, I remember someone who told me that she'd lost about 30 pounds. She felt much less anxious than she did before. So there's something to that. What is it from the change in the microbiome that happens? Is it reduced inflammation? We're not sure. But people who lose weight generally feel better. That's the big payoff from losing weight. And they feel psychologically better as well as physically better. In terms of drugs, we really don't know how these drugs work in the brain, the SSRIs and other drugs like Prozac and Zoloft, bupropion. We assume from mouse studies that this is probably the way they work. But I have to say, being at it for 30 or 40 years, I'm not sure I'm any worse than the psychiatrist in predicting what drug will help you the most if you are depressed or you are anxious. It becomes trial and error. It's not rocket science. But maybe I'm dumber than I think. Anyway, if you do need, and many people do benefit from these drugs, sometimes you got to work with your practitioner. If the first drug doesn't work, it's worth trying a second and even a third before you give up on that approach. Genetic biomarkers for what will work are developing. You can have a blood test, look at your genes, and say you will probably do better with Zoloft than with bupropion, that sort of thing. But they're not in wide use, and I'm not sure how reliable yet they are. Looking ahead chapter. Life expectancy, we mentioned, is below its peak from 10 years ago. In terms of studying people with their genes, 4% perhaps have actionable genes regarding prolonging life. And what actions do you take is a bit fuzzy in here, I guess. He talks about aging genes and how genes age and the telomeres, long versus short telomere. They're kind of if you have a shoelace, the two little plastic things at the end of the shoelace are like the telomeres on a DNA chain. And they prevent the thing from wearing out, so they're there. And they get shorter and shorter with time. But they have to be the right length. They can't be too long, can't be too short. How you fix that, they're working on that. And then there's proteasomes in the cell that do waste disposal for the cell. They get older and more decrepit as we age. Metformin and rapamycin might felt this. There's been I had one person ask me, can I have rapamycin? I said, I don't think it's really covered for anything. And it's not, but they haven't really shown that it does much. But it's out there as being touted as a longevity producer. And he mentions it. The benefits of calorie restriction are re-emphasized. We talked about the role of inter-organ communication and, of course, the role of inflammation. The gut microbiome, again, he talked about it looking ahead. Calorie restriction, benefits of exercise, SGLT, two drugs and GLP-1s. Estrogen replacement, it was a bad thing from the early 2000s to give women estrogen. It was supposed to increase the risk of breast cancer and stroke and everything after the Women's Health Initiative study. And then in the past year or so, they've said, we've relooked at the data and actually it's quite beneficial in the first 10 years of menopause. Okay, from say age 52 to age 62. It will actually help reduce risk of this and that and make women feel better. And so, as I've said before, if you're looking for received wisdom that never changes, go to church. Science is a bit messier than that, and you have to keep up with the science. Science is always asking itself questions and re-looking at itself. But right now, estrogen replacement is still something that women can think about in the early menopausal years. The lack of evidence really for rapamycin and metformin has got some good stuff about it, but there is, I guess, long-term muscle wasting with metformin. Mediterranean diet, maintaining normal weight, get outside, all these things. Maintain dental health, we want to re-emphasize hearing and vision. No proven rule. Okay, so basically that is it, finally. I wish you a long, healthy AZ journey. Do all these things. Be aware of changes in your body and discuss it with your doctor. Early diagnosis, we hope, is the key to successful treatment, and there may be earlier diagnosis that is going to be invented in the next decade or less. I would say science is now evolving exponentially with AI. AI will do something. I hope most of it is good. I hope all of it is good. But anyway, thank you very much. And